Good afternoon. I am Melissa Bauer, and thank you to SOAP for the honor to speak here today. I have no conflicts of interest to disclose, and today we will be talking about maternal sepsis. First, we'll go through the history of maternal sepsis, the definition, and incidence. We will also discuss why mothers die from sepsis and strategies to prevent those common pitfalls. Over time, several prominent women have suffered from childbed fever, as it was called in the past. Elizabeth of York, King Henry VIII's mother, and two of his wives, Catherine Parr and Jane Seymour, died of maternal sepsis. And Mary Wollstonecraft, the mother of Mary Shelley and author of Frankenstein, died a few days after giving birth to her from maternal sepsis. And most recently, the British singer Lily Allen had sepsis after a stillbirth at 6 months gestation and survived. Maternal sepsis was described as early as 1500 BC, and rates of sepsis were low because most women delivered at home. The first documented epidemic coincided with the medicalization of childbirth and lying in hospitals. This is an artist's depiction of a lying-in hospital. You have one woman here giving birth with a nurse attending to her, and within the same bed, you have a woman who's dying, receiving last rites. And over here, you have women who have died that are being passed over to these other women who are wrapping them in shrouds. So you have women giving birth and the dead and dying all in the same room. Lying in hospitals facilitated this epidemic as there was no knowledge at this time of sterility, and hospitals were overcrowded, and it was not uncommon to have 2 to 4 women in each bed. Contaminated instruments were used, and it was common to go from one delivery to the next without hand washing in between. Vienna General Hospital was one of the church-owned charity hospitals at the time. Poverty was very high, and to help, they allowed women to stay after delivery as long as they liked for free, provided that they delivered in the hospital or on the way to the hospital. And in return, they had to do housekeeping, nurse orphaned infants, and there were a lot of them because since maternal mortality was very high, they also had to knit clothes for the poor and submit to research studies. There were 2 separate admitting maternity services in that hospital, the midwife service and the physician service, and they alternated days for admissions. The physician service had a much higher mortality rate than the midwife service, and patients would try to get admitted on midwife admission days. They would try to hold out as long as possible until the midwife service was admitting to go to the hospital. When the midwife service was full, they were then admitted to the physician service. Dr. Ignaz Semmelweis worked at Vienna General Hospital and witnessed on many occasions women crying and begging on their knees to be admitted to the midwife service after it was full. He wrote about how upsetting it was that there was such a high mortality rate in the physician service and that they just didn't know why. So he set out to find out why and to fix it. So we made a number of observations. There was a lower death rate on the midwife service and also in the women that delivered en route to the hospital. And it was also much higher in winter months. But it wasn't until one of his respected colleagues, Jacob Kolechka, died after being cut with an autopsy knife that he realized he had the same features during his autopsy as the women who died from maternal sepsis. He realized that the women were dying from some type of contamination from autopsies. Then it all came together. The mortality rate was lower on the midwife service because midwives do not do autopsies, and women who delivered en route to the hospital were not subjected to cervical checks with contaminated hands. And the rates were higher in winter months since the trainees were spending more time in the morgue with the cold weather. So he had an idea to have everyone wash their hands upon entry to the maternal ward with a chlorinated lime solution. And as you can see here, the monthly mortality rates ranged from about 1% to over 30%. And once hand washing was instituted, the rates were consistently less than 5%. Dr. Semmelweis wrote about his findings and was met with resistance from the medical community. They didn't want to believe that they were the ones causing this problem, and they also didn't like the idea that their hands were not clean. So he met a lot of resistance from the medical community. He was ridiculed, and he lost his job. He was later admitted to a mental institution, and in a horrible turn of events, he died there from sepsis from wounds to his hands, and he died never knowing that he made a difference. As time went on, physicians adopted the theory that bacteria cause sepsis. Dr. Louis Pasteur identified hemolytic strep from a patient with maternal sepsis in 1879, and Joseph Lister, the British surgeon, introduced sterile techniques into surgical wards. These practices were later implemented in labor and delivery rooms, effectively decreasing sepsis and infection. So that was the past. So where are we today? So let's start with the definition. Recently in 2016, the definition for sepsis has been changed. It is now defined as a life-threatening organ dysfunction caused by a dysregulated host response to infection. And the term severe sepsis is no longer used out of redundancy. We no longer use SIRS criteria with infection to diagnose sepsis. Sepsis is now diagnosed by a score of 2 or more in the Sepsis-Related Organ Failure Assessment Score, or SOFA score. And here's how you calculate that score. It's based on a number of criteria. First, the P to F ratio, platelet count, bilirubin, pressor requirements, Glasgow Coma Scale, creatinine, and urine output. Now, if a patient has values that are baseline high, such as creatinine of 2, they would already have a score of 2. And in that case, it would be a change in SOFA scores of 2 or more. As far as a specific definition for maternal sepsis, the World Health Organization sent a survey to maternal sepsis experts across the world and reviewed the literature, and they now define maternal sepsis as a life-threatening condition defined as organ dysfunction resulting from infection during pregnancy, childbirth, post-abortion, or the postpartum period. And last year, the World Health Organization published a statement on maternal sepsis. They noted that there have been multiple interventions and initiatives to decrease maternal deaths, mostly focusing on hemorrhage and hypertensive disorders of pregnancy. However, sepsis, the third leading cause of direct maternal deaths, received far less attention. They've launched the Global Maternal and Neonatal Sepsis Initiative to raise awareness, develop more research, and ultimately reduce preventable maternal and neonatal sepsis deaths. And this has been endorsed by multiple organizations, including the Society of Critical Care Medicine. And consistent with the rest of the world, it is the third leading cause of pregnancy-related deaths in the United States, according to the CDC. And if you notice over time, the percentage hasn't changed very much, even with surviving sepsis guidelines starting in 2001. The rate is basically about 13%. And this is unlike other conditions that have decreased over time, such as hemorrhage, hypertensive disorders of pregnancy, and anesthesia complications. So what is the incidence? It's really challenging to determine the actual incidence due to varying definitions and case ascertainment, and especially with the new definition, it makes it even more challenging. So this was a population-based study in the United States looking at delivery hospitalizations only. So keep in mind, this did not report any of the admissions that were antepartum or postpartum. So these estimates are likely underestimated for the entire incidence of pregnancy. But out of an estimated 45 million hospitalizations for delivery, using the old definition for sepsis, sepsis complicated 1 in 3,000, severe sepsis 1 in 10,000, and sepsis-related deaths was about 1 in 100,000. And during outbreaks, pregnant women are especially vulnerable to infection. This slide reflects the H1N1 pandemic in 2009 that resulted in a large increase in maternal deaths from influenza. Almost a quarter of deaths were from infection during that triennium in the United Kingdom. And it's important to note that these deaths are largely preventable. These studies were reviews in North Carolina and Michigan and also the United Kingdom. They evaluated the cases and made determinations whether with different care there may have been a different outcome. The United Kingdom found that 47% of cases, 43% in North Carolina, and up to 73% in Michigan were most likely preventable deaths. So why do mothers die from sepsis? This article was a case series of all maternal deaths due to sepsis in the state of Michigan during that time. The deaths from maternal sepsis were reviewed, and three common themes emerged: delays in recognition, delays in escalation of care, and delays in appropriate antibiotics. And it's not that surprising that these things occurred, because delays in recognition happen because, as we'll talk about later, maternal physiology masks the signs of sepsis. There's tachycardia, there's an elevated white count. We'll go through that in a little bit. And delays in escalation of care occur because you have a young, healthy patient. And as you know from other types of morbidity, they look fine until they don't. So we're going to go through some strategies about how to identify that patient that needs escalation of care. And delays in appropriate antibiotics happen. And so that we're going to talk about what would be appropriate and how to come up with a protocol at your institution. So the rest of this talk will focus on improving our recognition, when to escalate care, and appropriate antibiotic therapy. So let's start with recognition. Which patients are at risk, and what screening tools should we use? Starting with risk factors. So this is a population-based study using California data. And there was increased sepsis found in those with factors of age greater than 25, those with less than or equal to a high school education, those reliant on public insurance, and cesarean delivery. They also studied which factors may increase progression to severe sepsis. And those factors include minority groups, those reliant on public insurance, those patients in hospitals where they have less than 1,000 deliveries each year, PRIMEPs, multiple gestation, diabetes, hypertension, preeclampsia, and postpartum hemorrhage. This is a study from the same group of authors examining data from Scotland, and they found an increase in sepsis in the following groups: those that were obese, age less than 25, anemia, and obstetric factors such as induction of labor, cesarean delivery, preterm delivery, operative vaginal delivery, and multiparity. Now, going back to that United States population-based study, independent associations for severe sepsis were found in the following groups. So age greater than 35, African American, those reliant on Medicaid insurance, retained products, PPROM, those with chronic liver, renal, or heart failure, HIV, lupus, multiple gestation, cerclage, and cesarean delivery during labor. So it's really challenging to be able to remember all of these risk factors. And as you can see here, most patients are going to have risk factors for sepsis. But the common associations across all studies were cesarean delivery, Medicaid or public insurance, multiple gestation, postpartum hemorrhage, and preterm delivery. However, many of these database studies do not have the temporality of sepsis with the delivery. So we're unable to determine which came first: cesarean delivery, postpartum hemorrhage, or preterm delivery. We don't know if that patient had a cesarean delivery first and then developed sepsis, or had sepsis and then developed a cesarean delivery, because either way, within that database, it may be associated with sepsis. So I do want you to know that some of these could be implicated by reverse causality. One of the most important findings of this United States study was that sepsis often occurs with no risk factors. And so surveillance systems should be developed to help increase disease detection. So that leads us to screening tools. With the new sepsis definition, it was recommended that screening outside of the ICU be done with quick SOFA. So these are bedside assessments that can be repeated over and over again and do not involve lab values, which is very important for low resource settings because they may not have that available. And this assesses for respiratory rate greater than or equal to 22 breaths a minute, altered mentation, and systolic blood pressure less than or equal to 100 millimeters of mercury. If a patient meets 2 or more, then that patient has screened positive for sepsis. However, this has not been validated in pregnant women, and a recent study evaluating different criteria for ICU admission in septic patients found a sensitivity of only 36% and a specificity of 89%. And none of those patients in that study had mental status changes. So these are young, healthy women, and even with severe disease, they may not have mental status changes until very late in disease progression. And this is problematic when you only have 3 criteria and one of them may not be helpful until the later stages of the disease. There have also been a few studies of the general population criticizing quick SOFA criteria that although they are specific, they may lack the sensitivity required to adequately identify patients with sepsis, and that SIRS criteria may be superior to identify more cases of sepsis. But more studies need to be done because obviously this is a new definition. So what about SIRS in pregnancy? So as we discussed a little bit earlier, we talked about maternal physiology masking recognition. So we're going to go through the SIRS criteria here, and temperature greater than 38 and less than 36, respiratory rate greater than 20 or PaCO2 less than 32, pulse greater than 90, and also white blood cell count greater than 12,000 or less than 4,000. So first we'll start with respiratory rate of greater than 20 or PaCO2 less than 32. This study was a meta-analysis that pooled studies reporting heart rate, respiratory rate, or PaCO2, temperature, and white blood cell count in normal healthy pregnant women to determine what is the expected range for those parameters throughout pregnancy and postpartum in non-infected healthy patients. And we had looked at temperature, and temperature was definitely, you expected it to be within the normal range. But now we're going to talk about respiratory rate. And if you look here, we all know that respiratory rate doesn't change in pregnancy, but we did have some women that fell outside of the range. If you see here, the dot is going to be the mean, and the solid line is 1 standard deviation, and 2 standard deviations is out to the end of the dotted line. So we did have some patients that would fall outside the respiratory rate, but even more striking is the PaCO2 less than 32, the great majority of those patients are going to fall within that, definitely at the end of the first trimester. And pulse rate greater than 90 beats per minute. All of these patients, as we discussed at the end of the first trimester, the heart rate changes about 15 to 25%. And so these patients that are young and healthy are going to meet that criteria as well. And going on to white blood cell count greater than 12,000. The white blood cell count can be quite high, especially during labor and delivery and immediately postpartum, just due to inflammation alone. So using SIRS criteria would inevitably lead to many false positives. And if you look here, many of these patients are going to be well above 12, especially that postpartum group and the labor groups. They can be, the postpartum group can be well above 20, and that's in a normal, healthy patient. So another screening tool is the maternal early warning criteria. And this is a set of parameters developed by the National Partnership for Maternal Safety to identify patients with impending maternal morbidity. And although this was not developed specifically to identify sepsis, the parameters were adjusted for physiologic changes of pregnancy. And the plan with maternal early warning criteria is that once a patient meets one of the triggers, a provider is contacted in order to assess the patient and escalate care. The parameters include blood pressure, diastolic blood pressure as well, heart rate, respiratory rate, percentage oxygen saturation, oliguria, and mental status changes. Going back to the sepsis death case series, this study evaluated how many patients would have met maternal early warning criteria. These patients, as you remember, all died from maternal sepsis, and these are their admission vital signs. 75% of them met maternal early warning criteria with admission vital signs alone. Now, if the care team had been alerted about these abnormal vital signs, Maybe there may have been an opportunity to escalate care or initiate treatment. There's really no way to know for sure if the outcome would have been different. However, with a functioning maternal early warning system, the care team would have been alerted and re alerted, and the opportunity to intervene may have come sooner. Now, take a look at these vital signs again. Many times it's just in one parameter that there's an abnormality. They won't necessarily have derangements in multiple parameters. And it's important to note that in many studies, including this one and the Saving Mothers' Lives reports, that there's quite a bit of missing and incomplete assessments. In addition, there's a large amount of respiratory rates recorded as 18, 20, or 24. And it's unlikely that everyone has the same respiratory rate. If the vital signs are not measured or not accurate, we will not be able to spot warning signs. We need to do our best to educate about the importance of accurate and complete vital signs. Another important observation is that only 2 of these women had a fever at admission. They do not always have a fever. It can certainly be transient. And although more studies need to be done, maternal early warning criteria are adjusted for pregnancy and they're designed to detect impending maternal morbidity. And the additional benefit is that the criteria screen for multiple types of morbidity with one screening tool. But some might ask, why would we need a maternal early warning system? So everyone bear with me here because I want to switch gears and provide a very similar example to a serious public health issue. So just as there are many initiatives to reduce maternal deaths, there are also initiatives to reduce child deaths. So drowning is the second leading cause of accidental death after motor vehicle accidents. And in a review of drowning deaths, most of the deaths were from a result of lack of supervision, but a surprising 11% of the deaths occurred during supervision, with the caretakers actually watching it happen. The problem is they just didn't recognize the signs of drowning until it was too late. It's not the presentation you would expect. There's no waving arms or screaming for help, but when people are trained about what to look for, they can recognize what's going on and respond appropriately and hopefully make these deaths preventable. So take a look here at this pool. Pretend this is the labor and delivery ward. You have multiple patients to care for, but at any one point, one of them could be in trouble. And with so much going on, how can we recognize the signs of someone in trouble? How can we keep track of everybody and be able to zero in on the one who may have an issue and quickly so that we can respond appropriately and help them, just like this lifeguard? So, first, we have to start with education. So, what does someone in trouble look like? So as you can see here, this education includes this person's head is bobbing above and below the water surface without enough time to breathe above the water. This person's head is tilted back to try to get his or her head above that water. And this person's body is vertical in the water and the legs are not used because the body is prioritizing arm movement to propel above the water. The arms are stretched out wide to the sides to try to push down to propel out of that water. And they can't wait for help. And they don't make a sound because the body prioritizes breathing over speech. So now let's take a look at this again. Now you've been educated about the signs. Now let's watch again and see if you can spot the child who's in trouble. So here we go. This person is bobbing up and down above the water. There's no time to breathe during that time. You recognize that now. and the arms are wide to the sides, trying to pull up out of the water. And now look, she's got him. So this child was fine because that child had a lifeguard who was educated and ready, and she quickly responded to his distress. And that's exactly what an early warning system can do for you. It can educate everyone about the signs of someone in trouble, and you can recognize it. Everyone else can recognize it. The nurses can recognize it, and you can jump in and intervene promptly. Now let's move to escalation of care. So this is an ACOG practice bulletin using vital sign triggers for ICU admission from the guidelines for ICU admission from the Task Force for the American College of Critical Care Medicine. Now there are multiple other criteria, but we're focusing on specifically vital sign parameters for this discussion. And the parameters of a heart rate greater than 150, blood pressure less than 80, and a respiratory rate of 35, those patients should definitely be considered for ICU admission. And this will be covered in more detail in Jen Hofer's webinar in September about ICU admission. But this seems very obvious. So how can we calculate this a little bit better? So there is actually a more specific scoring system to determine ICU admission in pregnant women with sepsis, and that's the Sepsis and Obstetrics score, the SOS score. So the SOS score is based on measurements of temperature, systolic blood pressure, heart rate, respiratory rate, pulse ox, white blood cell count, percentage of bands, and lactic acid. And in studies, a score of 6 or greater predicted ICU admission in both retrospective and prospective validation. But in the middle of the night, you may not remember who this author was, the name of the article. And so I want to tell you that there's an easy way to find this. On perinatology.com, they have a sepsis calculator. And the last time I was on that website, I think it was flashing in red and had some stars around it. So it's very easy to find. So go there, and right here, you can choose drop-down values about what values your patient has, and it will calculate the score for you. But consider transferring that patient to the ICU with a score of 6 or more, or worsening clinical status, or if you have some more clinical concerns about that patient, you should transfer them to make sure they get adequate escalation of care. Let's move on to antibiotics. So this is the most important treatment, as you all know, with sepsis. So it is common that inappropriate antibiotics are administered. And the timing is very important because it has been shown that for each hour of delay in appropriate antibiotics, that this increases mortality by 7.6%. And in this study, only 13% of patients received appropriate initial antibiotics. But after ICU or ID consult, that percentage went up to 67% that were appropriate for the clinical situation. And in the remaining patients, 20% of them didn't live long enough to get subsequent therapy. And 13% of them, the appropriateness was unable to be determined by the information that we had. So based on this information, you should try to develop a protocol and have it in place before your patient gets sick so that in the middle of the night, you've already had a plan that you've set up with your ICU or infectious disease team about what would be appropriate to give in this situation. But I would always also recommend that you have it accessible as well. It wouldn't be helpful to have an antibiotic that you still have to call ID for to get approval in the middle of the night that's only given out by one particular pharmacy within your hospital system. You want to make sure that it's something very accessible. Ideally, it would be something that you can have in the Pyxis so that you can get that antibiotic in that patient very quickly. The other important thing is that when you have a critically ill patient like this, you're going to be writing multiple orders. You may even have about 20 orders there. So you want to make sure that you go back and circle back to the nurse and make sure that you communicate about what needs to be prioritized first. So that's really important so that they know that these antibiotics need to go in before anything else. And offer to give more IV access so that they can run more than one antibiotic at a time. So in the OR, we're used to giving antibiotics pretty rapidly with the exception of a few of them. And on the floor and in the ICU, they have very long run times in their antibiotics. Many of them are an hour and sometimes even more. And you want to make sure that you give them enough IV access so they can run more than one antibiotic at a time. They may consider certain antibiotics non-compatible with each other, and they're not able to run it through the same IV, or even the same, if there's multiple ports on an IV, they may not be able to do that. So you want to be able to offer them that solution so that they can give all the antibiotics and get them all going. Because if they have an hour long time on a gram positive coverage and they don't get the gram negative coverage for another hour, then that's really a problem. So you want to be cognizant of that and offer more IV access so they can get those antibiotics going. And from the Surviving Sepsis campaign, how fast should you be giving it? And they recommend that you should give it as soon as possible and definitely within 1 hour for both sepsis and septic shock. So what do we need to cover? So the most common bacteria are E. coli, staph, strep, and other gram-negative bacteria. This was a very nicely done review that was written by Barton and Sabai. And they did a lot of the kind of earlier studies in the 1980s about maternal sepsis. And they wrote a beautiful review that was published in the Green Journal a few years ago. And based on their review of sepsis and pregnancy, they recommended for specific broad spectrum antibiotics for obstetric patients, either a combination of vancomycin and zosyn, or penicillin, gentamicin, and clindamycin. And I'll say one more word about that. So it says on here, do not delay therapy while awaiting cultures. I do think that that's really important. Yes, it's important to get cultures, but if it's going to take 20 minutes to get those culture bottles and nobody knows where those blood culture bottles are, you cannot wait for that. And it is important to try to figure out what they have. So if you have it available, sure, draw them, start the antibiotics as soon as you finish putting the blood in the bottle. But you don't ever want to delay therapy while awaiting doing blood cultures or multiple other cultures, if you can help it. Another thing I'd like you to consider is that in patients with septic shock, you may want to consider combination therapy. Now, combination of therapy is not broad spectrum therapy. It's defined as 2 antibiotics of different classes aimed at the most likely pathogen. So a good example of this is adding clindamycin to already broad gram-positive coverage. So there are some studies showing that with clindamycin and beta-lactams, that in group A strep infections, there may be a survival benefit. And there's also some animal evidence that clindamycin may decrease toxin production. And there's enough group A strep in this population. It's definitely not the most common infection they get, but there's enough of it in this population that I think its use is warranted in septic shock situations. From the Surviving Sepsis campaign, other steps for initial resuscitation include that within the first 3 hours, you want to make sure that you give at least 30 mLs per kilogram of crystalloid fluid. Now, beyond that, you want to be guiding your resuscitation after that. You want to make sure that you're reassessing their volume status, their hemodynamic status, and also they do suggest that you guide your resuscitation somewhat to normalize lactate in patients with elevated lactate levels, because lactate levels can be a marker of tissue hyperperfusion. The other thing that you also want to do is recommend an initial mean arterial pressure of 65 when you're using vasopressors in these patients. And you all know that the first line for vasopressors is norepinephrine. And if you find yourself on escalating doses of pressors, then that's the time to consider starting vasopressin to decrease your norepinephrine requirement. Now, with vasopressin, you want to make sure that you stick to a physiologic dose. You don't want to be escalating on that dose because it does constrict the vascular bed in the gut. So you want to make sure that you're not doing that. You want to keep it to physiologic dosing. Well, what's physiologic dosing? The Surviving Sepsis campaign recommends 0.03 to 0.04 units per minute. It's not necessarily weight-based, but that basically rounds out to be about 2 units per hour. So definitely keep it in that range when you're, if you need to use it to decrease your norepinephrine burden. So, in summary, sepsis is a rare but preventative cause of maternal mortality. And after this lecture, I'm hoping that you take the time to develop protocols at your institution before you have a patient who shows up this way. Because you know, with the incidents, that most likely at the centers that are all viewing this right now, you're probably going to have one of these patients at least a year. So you want to make sure that you're ready when they come in because there is no time for you to figure things out later. So first start with screening tools. I think it's important, and so does the Alliance for Innovation on Maternal Health. They recommend that there's some type of screening tool, and they do recommend maternal early warning criteria, that you have a system in place to let you know if a patient's at risk for developing maternal morbidity. So you want to have something in place, and it's preferable to have something adjusted for pregnancy and also a screening tool that screens for multiple types of maternal morbidity. An antibiotic selection, I do encourage you to set that up now before you have something so you can refer to it when that patient does show up. You want to make sure to have broad spectrum therapy, even if you think you know what's going on. When they come in septic shock or septic, you need to make sure they get broad therapy. You can narrow it down later. And also consider clindamycin in those patients that show up in septic shock. And about deciding when to escalate care and transfer to the ICU, I do recommend that you pull up that sepsis calculator and see if that patient needs to be transferred. But if you have concerns, you don't even need to pull up the calculator. Go ahead and transfer them because you want to make sure that they get the adequate attention and help that they need. And I'd like to thank the University of Michigan for all their support, as well as SOAP. And Casey was one of the research assistants last year. He helped me obtain a lot of the copyrights for many of the pictures that I used. And with that, I'll take any questions.